essentially showing what the upper airway looks like, and we expect to see crisp vocal cords just like that. And my example first was a flexible nasal laryngoscopy performed in the office. I'll let the video play. Is the video playing? Okay, excellent. And so that's just essentially a large cyst that is, as you can see, obstructing the airway. And this is a vallecular cyst. It can present as an emergency. And then my next video was just showing that this is potentially a challenging intubation that's performed via rigid instruments, routinely or usually by an ENT surgeon. And that's just a rigid scope that is in with a tube railroaded over it, and then you insert the tube and remove the scope. And this is a picture of before excision and after the excision. We routinely excise it on block. Some people do a marsupialization, but this was on block. And as I mentioned, I had two or three that I've encountered since I moved here to Qatar, and it's been about 2 years. So my objectives for this presentation, I wanted to initially keep it a bit broad, which is just to understand the collaborative management of pediatric airways, to understand the pediatric airway in contrast to the adult, to mention and recognize some common pathologies that affect the pediatric airway, specifically highlighting subglottic stenosis. We'll talk a bit about the equipment that's used for diagnostic airway assessments and the evolution of pediatric airway surgery. So I practice in Doha, in Qatar. That's a picture of our hospital. It's called Sidra Medicine, which is the national children's hospital, not only for this country, but for regional areas as well. It's a wonderful hospital. If you ever get time to visit, you're more than welcome to visit our division as well. We do a lot of complex tertiary work. And one of the concepts I wanted to introduce you to as we discuss or think about pediatric airways is a shared airway model, because a lot of the surgery that we're doing is in a space that is going to be managed by us as the surgeon, but also by the anesthesiologist that is concomitantly trying to oxygenate these patients as we operate in the larynx. And so this is a very good example of a patient that needed a shared airway approach. As you can see with this baby, there was a large mass essentially obstructing the airway, and this was picked up in utero. And we planned for a essentially a delivery or an intubation just after the delivery. So the mother was had an emergency cesarean section just opposite where I was set up with my air equipment, and then was brought to our operating room where I and the anesthesiologist was then planning the airway securement. And so what I wanted to show first is the equipment that we have. As you can see, I'm starting with the laryngoscope that has an oxygenation port. And that's important because that just gives you a bit of oxygen and potentially some time as you're finding and securing the airway. Remember these patients, there's the anesthesiologist here that's working with me here, but she has no line access. Remember, this patient has just been born. So this patient essentially is almost basically wide awake. And then once you've put your laryngoscope inside, you can see this is the mass that's partially encroaching into the view of the airway. You identify the glottic inlet, you go in with your scope. And remember now your scope, similar to the previous video, has an endotracheal tube that's over it. So it's railroaded over it. And so once you go in with your endoscopic view, you then get a diagnosis, and then you essentially pull out the endoscope and you leave the endotracheal tube inside. So basically in about 20 seconds, you're making a diagnosis and you're also securing the airway. But when you're managing these complex pediatric airways, it's important to think about this shared airway concept. Okay, so in these scenarios and other scenarios, it's important to have your plan A, your plan B, plan C when you're thinking about securing a pediatric airway. As you can see here, I had my scope with an endotracheal tube railroaded over it. You have a couple of different kinds of laryngoscopes for me. This is a Parsons. You can see my pointer, right, Nawaf? Okay, all right. So yeah, this is a Parsons laryngoscope. This is a Miller. I have a rigid bronchoscope as well, and a couple of different sizes of endotracheal tubes. So a bit about the anatomy when you think about comparing pediatric versus adult airways. A child is not a small adult. There are important differences that you should think about when it comes to a pediatric airway. Um, the first is that the tongue is actually proportionally larger than the adult tongue. So when you're actually going in and performing a laryngoscopy, you need to be a little more aware about tongue position and how you appropriately place your laryngoscope. Your epiglottis is a bit more floppier, and therefore, usually placing your tip of your laryngoscope in the vallecula is the ideal place to be. Um, your larynx is a little more anterior and superior, especially in infanthood, and therefore, you practicing laryngoscopy is really, really important to ensure you have a good view of the vocal cords and the glottic inlet. And very importantly, and we'll talk a little more about this, is that the airway is sort of apexed at the cricoid area. And that is one of the big reasons why subglottic stenosis is more common in children compared to adults. Okay. So when you look at the larynx itself, you expect to see crisp vocal cords just like that. That's the supraglottic area with the epiglottis, the arytenoids, the vocal cords below the subglottic area and the trachea. And side by side to this as well, I just put in some images of what stridor quality would sound like depending on where the pathology is. Now, this is not always the case, but generally follow this pattern where if you have pathology above the vocal cords or at the level of the vocal cords, you have an inspiratory like sound. When you have more of a glottic subglottic pathology, there's both of an inspiratory and expiratory sound of stridor versus something that's more intrathoracic, where you have an expiratory stridor-like sound. Okay, so now that we mentioned stridor, it's really important for you to recognize the sound. And recognizing the sound, obviously, you're thinking about how severe the sound is, but also trying to differentiate it with stertor. Okay, so I'm just going to play these videos here. I hope you can hear the sound. You hear the sound? Not really? Okay, all right. But it's like a squeaky, high-pitched inspiratory sound, like, and that we know is very different than stertor. Can you hear that sound? Okay. But stertorous is more sounds that come in from the nose, the adenoids, the oropharynx, where you essentially have sounds that are mimicking things like when you hear with kids that snore. Okay, so it's important, first of all, as pediatricians or general practitioners, to first of all differentiate between those two sounds when you're considering your differential diagnosis. Okay, now we'll start with the supraglottis, then move to the glottis, and then the subglottic area as well. But the supraglottic area, and I've picked sort of the most common pathologies for each of those areas for us to go through. And for the supraglottic area specifically, I was going to play these videos, and maybe somebody can go ahead and volunteer what diagnosis they see. And I'm going to play the second one that essentially is the same pathology. But if somebody wants to write in the chat or unmute themselves and go ahead, please, you can mention what diagnosis you feel this is. Note takers? Okay. Okay, great. I see Priyanshu Shah that mentions laryngomalacia. Absolutely. Spot on. And with laryngomalacia, as you can see, you have that arytenoid or redundant arytenoid prolapse. As you can see in the glottic area, you can see a bit of redness, and you see tight area epiglottic folds that are pulling the epiglottis into almost like a taco shape, just like that. So those are very typical features of laryngomalacia. So well done, Priyanshi. And so you commonly have inspiratory stridor, right? Because this is the supraglottic area. You have dynamic supraglottic collapse, as I mentioned. Usually it's worse when supine, when the child is active or feeding. It's important to think about synchronous airway lesions that may be present. That's where you always do a diagnostic scope on these kids. You make this diagnosis just with a flexible scope in the office, similar to what I showed. Um, and when you're thinking about deciding whether to watch, to give medication versus surgery, it's based on your symptoms, the weight gain of these patients, and the appearance of what you see on flexible laryngoscopy. And so for kids that have minimal retractions, have minimal difficulty in feeding, they're otherwise sleeping well with no apneas, their trajectory is either stable or improving and have no or very few comorbidities, it's acceptable to actively observe these patients. While kids that have deep retractions are faltering on their growth curve, have apneas, very poor sleep, with severe symptoms and unfavorable progression, then you may be thinking about surgery a bit sooner. And when you think about the surgery, the two levels that you commonly would go ahead and target is one, I mentioned the airy epiglottic folds, right? So the arytenoids, epiglottis, you have these airy epiglottic folds, right, that are pushing the larynx almost closed. And you have arytenoids, these arytenoid cartilages right here, as I mentioned, that are prolapsed. And so you would go first of all and release the airy epiglottic folds. And this is done with under endoscopy, as you see, via the mouth. And just by doing that, as you can see with the next picture, you're already seeing what that does to the larynx. It already starts opening it up and giving you more supraglottic patency. The next step is to then reduce the arytenoid or the redundancy of the arytenoid cartilages, and you frequently go and trim not only the redundant mucosa, but a bit of a slice of the cartilage itself as well. You basically skive it, the cartilages. Um, and if you do a good supraglottoplasty, you will see benefits almost immediately. There's usually a bit of swelling for a few days after this kind of surgery, but over the first week or so, you should see significant benefit in the right patient. Okay, the glottic area, I just wanted to show a video of this, and there's a lot to discuss with this, so we might not have time, but at least if we can just pick up the diagnosis, that probably would be useful as well. So I'm going to play this video, and then I would have anyone who wants to participate, go ahead. So Priyanshi mentions Reinke's edema. It There is a bit of edema there, that's true, but that is not the primary pathology I was looking for, but very good try. What if I show you this next picture and you will now see that the vocal cords themselves actually are not performing a full abduction or abduction, right? So they're kind of, you can see that they're trying to move apart because there's air moving in and out, but they're not actually performing full abduction. So they're not opening fully, right? And so that's a common or relatively common reason for stridor that we see as well in our office, which is bilateral vocal cord immobility. But Priyanshi, good job in identifying that the vocal cords may have some issue. And as I mentioned, this is the second most common cause of neonatal stridor. It's responsible for roughly about a tenth of pediatric tracheostomies. You could have inspiratory or biphasic stridor in these kids. And usually, when you're thinking about differential diagnosis, you need to scan the posterior fossa of the brain to rule out an Arnold-Chiari malformation. but most of these are idiopathic. Okay. Okay, good. Let's now move on to the subglottic area, and this is something that I see way more of compared to the bilateral vocal cord immobility. And I will play this video, and again, somebody can write in the chat box or comment on what they see. Okay. Yes. Any comments? Okay, good. So I see Ruqayya Al-Mari that mentioned subglottic stenosis. So yes, absolutely. There's stenosis in the subglottic area for sure. So you can see that there's almost basically no airway, right? Like there's edema and narrowing and stenosis. So these are the vocal cords, and immediately below that, there's almost no airway. And as a background, in terms of history, this patient came in at like 10 p.m. at night to the emergency department in severe distress. So this needed to be done more emergently. Um, and what I really wanted to highlight as well in when you're thinking about a subglottic stenosis is the structure of the subglottis. So the subglottic itself is between the true vocal cords to the inferior aspect of the cricoid ring. And it's housed within that cricoid cartilage. And this cricoid cartilage is the only complete ring of cartilage, right, in the entire airway. And it's non-expandable and non-pliable. And that means, like, if there's force within the lumen of the cricoid cartilages, the force doesn't dissipate anywhere else. It actually dissipates inside. And that's why you get intraluminal narrowing. There's no muscle, but the trachealis muscle in the trachea can dissipate some of the force with trauma posteriorly. But with the cricoid specifically, there's no way that force actually goes outside. And so when you're thinking about diameters and measurements, usually a newborn baby should accommodate a 3.5 endotracheal tube. And remember, the 3.5 millimeter endotracheal tube for a term infant means the inner diameter is at 3.5. The outer diameter is usually about 4.5, 4.6. So if that child cannot fit a 3 uncuffed endotracheal tube at birth and is a term baby, by definition, that patient has a narrow cricoid or a narrow subglottic area. All right, so that's usually what the subglottic area should look like. But a lot of the kids that we see who have conditions or that have subglottic stenosis would look like that. And essentially, when you think about the narrowing and you're thinking about comparing an adult airway versus a pediatric airway in terms of stenoses and how emergently you need to manage, all you need to think about is the cross section and the resistance. And so I will just give you this table here that says for a 4 millimeter diameter of a pediatric airway, comparing that to a 12 millimeter diameter for an adult airway, if you narrow both of those by just 1 millimeter, with a pediatric airway, you're reducing the cross-section by 75% and you're increasing the resistance by 16-fold, right? And so if you look at the different straw tips, and I just put that deliberately there as well. So a skinny straw that you would normally use for iced coffees and iced teas and that kind of stuff, it's about 7 millimeters, right? So you're thinking about a 4 or 5 millimeter airway that's actually narrower than that straw that you'd be sipping your iced coffee with. So that's why when you're thinking about edema and stenosis, that is why there's a certain urgency and emergency to it. And it's not something that should be lightly taken when it comes to time. Okay. So there's a Meyer-Cotton classification that looks at the degree of the stenosis or the obstruction. A grade 1 stenosis being 0 to 50%, a grade 2 stenosis being 51 to 70%, grade 3, 71 to 99%, and a grade 4 stenosis essentially means that there's no detectable lumen. Okay, so I'll take you back to this patient that has the stenosis. And my next question to you guys is, what do you think caused it? Like if you had to pick one thing in the world, it could be infectious, it could be, you know, tumors, it could be congenital, it could be anything. What would you pick caused this patient's subglottic stenosis? Mm-hmm. Mm-hmm. Any takers?
Tumor.
Uh, sorry, I missed that. Say that
Yeah,
again.
a tumor.
So a tumor in an adult patient, absolutely, that would be big on your differential diagnosis. But
And the,
tumors in kids in the
yeah,
subglottic
most
area
possibly
are
congenital
relatively rare.
causes. Yeah.
It could be congenital, true. And I see Layla had written prolonged intubation. Absolutely. That's absolutely the correct answer. So prolonged intubation causes over 90% of an acquired or any subglottic stenosis. So that's absolutely correct. And I like the fact that you not only wrote intubation, but you also wrote prolonged intubation as well. That's great. And we'll discuss more about risk factors just now. But with congenital subglottic stenosis, usually it's because of the laryngotracheal tube that fails to recanalize. But the vast majority of stenoses are acquired, and over 90% are because of endotracheal intubation. And so when you think about the pathophysiology of a subglottic stenosis that's acquired, it's essentially just an exaggerated wound healing response, right? Where you have inflammation, you then have proliferation of cells and remodeling of those inflammatory cells. And usually this is initiated by high compressive forces of the endotracheal tube. So like a large endotracheal tube that's sitting there, or a hyperinflated endotracheal tube cuff, causing pressure necrosis, mucosal edema, and ulceration. And eventually that causes granulation and narrowing, and then stenosis, right? So you want to pick up these stenoses at an area in which it hasn't started remodeling, and we'll discuss a bit about that. And when you think about predisposing factors, most of these, as I mentioned, are because of an acquired cause, because of intubation. And the next question is how many, what's the percentage of you getting a subglottic stenosis after you've been intubated? And that varies in the literature. Okay. It varies anywhere between 0.3 to over 11%. Um, and if you look at this study specifically, which was about 10 years ago now, that was linking prolonged intubation to a subglottic stenosis, that showed for every 5 additional days of intubation, there was about a 50.3% increase in the risk of developing a subglottic stenosis. And so prolongation is one. But that's not the only one, right? So there's also traumatic intubations. You know, many of us deal with learning students, residents, fellows who are learning, and naturally a progression of that is maybe potentially causing some irritation or trauma as you intubate. Repetitive tries, again, that may worsen that trauma. Compressive tubes, and this is a big one and something that we can easily correct in all our institutions tomorrow, which is essentially using the right size and not an oversized tube for these kids, and also regularly checking the cuff pressures of these endotracheal tubes. Because if you hyperinflate these cuffs, and when you're thinking about hyperinflation, you're thinking about over 25 to 30 millimeters of mercury, and microcirculation ceases. Okay, and that again goes back to the inflammatory cascade. Kids that are premature, that already have irritations like reflux or meconium aspiration, or are malnourished, or have anemia, may also be further predisposed to getting a subglottic stenosis. Okay, this slide was now looking at NICU graduates that were essentially comparing kids that were born less than 28 weeks of gestation versus over 28 weeks. And again, because they were really small and premature, this was again linking them to trauma in the subglottic area. And again, was highlighting that if you have a high number of intubations, a longer duration of ventilation, unplanned extubations, traumatic intubations, and oversized endotracheal tubes, again, this would predispose you to a subglottic stenosis. Okay. Um, the clinical presentation, I think we've talked about already, but you could get stridor, that's usually inspiratory or biphasic. If it's quite severe, you could get use of accessory respiratory muscles. And then you need to go through all the risk factors in your history, as I've previously mentioned. When you're thinking about the diagnostic workup of these patients, you routinely start with a flexible laryngoscopy. And again, that would be important to rule out any supraglottic pathology, glottic pathology, because remember, these patients have stridor, right? But they may also have laryngomalacia. They may also potentially have a bilateral vocal cord palsy. So it's important to actually identify that dynamically before you then take these patients for a rigid endoscopy under anesthesia to then evaluate the subglottic area specifically. And you'll also, in your armamentarium, is flexible bronchoscopy, which is then used to look at the trachealis muscle and looking at tracheomalacia and lower airway bronchomalacia as well. Okay. A bit about laryngoscopes. We not only look at the length of the laryngoscopes, but also the circumference of them, because that has a consequence of how you go and then retract or move the tongue away. I routinely use the Phillips or the Miller laryngoscopes, but I think different centers and different people prefer different laryngoscopes. But this is just a note to look at it's important to understand what kind of laryngoscopes you have and how you use them. I also specifically wanted to mention these two laryngoscopes that we have an oxygenation port attached to them. This is a Lindholm laryngoscope and a Parsons laryngoscope, and they both have suspension handles as well. And a suspension microlaryngoscopy setup looks exactly like this, where we're able to actually perform two-handed surgery using the microscope in the larynx and the glottic area and the trachea as well. Okay, so a bit about management of the subglottic stenosis. So the primary aim of managing a subglottic stenosis is to avoid a tracheostomy. So, decades ago, this was the primary modality to manage these patients, where you just bypass the stenosis, you go below it, and you perform a tracheostomy. But I think in this day and age, our aim is to actually avoid a tracheostomy. And we have excellent tools at our disposal endoscopically that we can do, which includes balloons, micro instruments, lasers, coblators, and we've become very good with endoscopic works that actually prevent us from even doing open airway reconstructions or tracheostomies, as I mentioned. But if endoscopic measures fail, then you have the option for laryngotracheal reconstruction, where you split open the cricoid, and then you can either augment that split with grafts, anteriorly, posteriorly, or even sometimes both. Thirdly, the option is to resect that stenotic portion, and very, very last, for failed cases, then you may consider a tracheostomy. Okay. I'll give you just examples of what an endoscopic airway surgical procedure looks like, where we routinely go ahead and we dilate the subglottic area. We inject steroids in those areas as well, to try to minimize the effect of inflammation or start to reverse the inflammatory process. So this case that came to us, as I mentioned before, at about 10 p.m. one night, was actually intubated at an outside facility for about 3 months. They were then discharged home a month after they were discharged from their ICU and presented to our facility with inspiratory stridor. So that patient we took in, I hope this video is going to play. So we took in, that's with a balloon that's going in, and there's different sizes of balloon depending on the size of the child's airway and the age of that child. We would go ahead and inflate it at certain pressures. We then would visualize what that looks like and go to the areas that were affected by that stenosis, inject steroids into those areas, and then again, once more dilate so that you're pushing that steroid into where it needs to go. And then you're getting a more patent airway. In this patient, we were lucky because this patient still had a nice soft stenosis, so we're able to go and get a good result. It did take 2 to 3 endoscopic procedures, but eventually able to get a good result. But if this patient presented a little more late, then we may have not gotten this kind of result. Okay, so as I mentioned before, the goal is to pick up these patients in that inflammatory proliferation phase. But if you get them in that remodeling phase, they may not be able to actually, they may not tolerate, or you won't be able to reverse that stenosis with endoscopic measures. And so something like this stenosis is not soft anymore. It's firm, it's hard. And so for you to be able to perform an endoscopic procedure here, you would need to do other things like laser, excisions, coblations before you think you can get some more of a diameter. And if that doesn't work, then you're thinking about open airway surgery, where you essentially would go and split open the airway. That's why it's called open airway surgery. And you would typically split the subglottic area and the lower part of the thyroid alar cartilage. And you then consider augmenting the split. So in the 1980s, when this procedure was invented, essentially, they would only split the airway, and then they would leave them intubated. And the success rate was about 50-50. But then they realized if they then augment that split with cartilage, success rate shot up. And so you not only split the cricoid anteriorly and posteriorly, and then you'd put a piece of cartilage there. And the cartilage could come from the thyroid alar, it could come from your rib, it could even come from the auricle itself, the ear. I routinely use costal cartilages because I find there's enough cartilage, and it's also quite firm and robust. So my go-to is usually rib cartilage. And these are just a couple of different pictures where this is demonstrating a open airway. So again, that split is happening through the cricoid and the lower part of the thyroid alar. And then this is rib cartilages that is then fashioned appropriately and then positioned. Okay. And when you come, usually about a month to 6 weeks post-operatively, you can see a well-integrated anterior graft that's sitting nicely with a well-expanded airway. Okay, and I think my last example, and I think we're nearing the end of my presentation, so I've talked about the supraglottic area, we've talked about the glottis, we've talked about the subglottic stenosis and what management modalities that we have. I wanted to briefly mention the trachea and the lower airway, and this would be investigated both by means of rigid endoscopy, but by also flexible bronchoscopy that can essentially go to the most distal parts of the airway to evaluate pathology and also the dynamic movement of the distal airways. And so this example is of a patient that actually had a tracheal stenosis secondary to compressive forces of the endotracheal tube. This is way down here in the trachea. And you can tell this is the trachea, right? Because this is all muscle, the trachealis muscle. Remember, the cricoid area does not have muscle posteriorly. So this is all the trachealis, and this is the tracheal stenosis. And this was actually a patient, Nawaf, that was sent to us by the Kuwait team. So it was a Kuwaiti patient that came to us, and we scanned them and we did bronchoscopic evaluations, and we found that the airway was essentially squished by a narrow thoracic inlet. So the sternum here was essentially pressing onto the airway, onto the innominate, onto the airway, and onto a kyphotic spine, as you can see here. And so we had to get our general surgery team, our cardiothoracic surgery team, and then as well as me to manage the airway itself. But what we had to do for this case is we had to split open the sternum. We then repositioned the innominate artery and then place the cartilage graft to keep the sternum nice and expanded. And once the thoracic inlet was expanded, then the tracheal stenosis was managed essentially by our team. And what worked really well for me in this case was laser. So this is an example of me working on that stenosis with laser. And as I showed you before, I routinely also inject steroids in this area. So I would go in ahead, I would remove the stenotic parts with some instruments, whether that's laser, whether that's cold steel or coblation. I'll then go ahead and balloon dilate that area to give me some more space. Um, and as I showed you before, just to inject some steroids in that area just to reduce uh, the inflammatory component of this stenosis. Okay, so eventually this patient who came to us with a stenosis that looked like that, ended up with a nice patent airway and uh, went home on room air. I believe is still in Kuwait doing very well. But it's important just to think about pathology in the lower airway as well when you have a patient with stridor. Okay. So I've talked a bit about laryngomalacia, about vocal cord immobility or paralysis, about subglottic and tracheal stenosis, but there are a lot of other pathologies that may cause stridor in a child. And so I didn't want to say that what I've mentioned is completely exhaustive, but they could be massive neoplasms, foreign bodies, papillomas, hemangiomas, infections, webs, cysts, vascular compression that you have to think about in the pediatric population. And maybe one day we'll get time to speak about some of those other pathologies, but at least for today's discussion, it was more about the more common things that we see. Okay, so as a summary, it's important first of all to recognize the sound, your stridor, understand exactly what it is. You then classify the severity of the sound of the stridor. You then consider what predisposing factors that may be for this child may have, whether it's prematurity, a history of endotracheal intubation, traumatic intubations, how long were they intubated for, what is their birth weight, reflux. And then you start thinking about where this pathology might be. Supraglottic area, glottic area, the subglottic area, and the trachea and the lower airways. Okay. So thank you very much. It was a pleasure speaking to you guys, and thank you once again, Nawaf, for your kind invitation